Good afternoon, everybody. I guess this session is a session that's holding you away from lunch. So thank you for those who are staying with us. And I'm going to talk about a topic that I'm sure you all are asking yourselves, why is this important for us as pediatricians? Is that something that we will be dealing with? And yes, that's something that you might be dealing with in the emergency room, in the ED. And some of those medications you might be starting actually in the ED before the kiddos are stable enough to be transferred to the ICU. So the objectives of my talk, I'm going to first say some terms, the glossary of some of the terms that we will be using throughout the talk. I'm going to talk a little bit about receptor types and physiology, and I think it's important so that we can understand the language as we go through the talk. And then I'm going to talk about some of the few medications that are in use, and then some of the change in practice that is being suggested and that have already started in a lot of places, and then some final thoughts. So it's all about, I think Khalid will enjoy this slide when we say that this is all about the heart. And the heart, whatever the heart gets, the heart is going to pump out. And it's the cardiac output that determines it all. And what determines the cardiac output actually? It's the heart rate, it's the contractility, it's the preload and the afterload. So the contractility is how strong the heart is going to be pumping. The heart rate is what kids do a lot of times. Via compensation, they compensate for their cardiac output by increasing their heart rate. And this is something that you see so frequently in kids that we tend to forget. I mean, we don't pay that much attention to it. A kiddo who has a heart rate of 170 and he's less than 1 year of age, I mean, so it's not a big deal. Whereas if an adult has a heart rate of 170, everybody will be panicking. And then the preload, which is whatever gets to the heart so that the heart will be able to pump it. And the afterload is the pressure that the heart is trying to pump against. When we say the word inotropes, what does the word inotrope mean? Inotrope is any medication that will improve myocardial contractility and it will enhance stroke volume. Pressors are, on the other hand, medications that will actually improve the vasomotor tone and it will increase the systemic vascular resistance. And a lot of times we use those words interchangeably, but actually they're not interchangeable. Some of the drugs can be inotropes and pressors at the same time, and some of the drugs are pure pressors, and some of the drugs are pure inotropic medications. Chronotropes are medications that are actually used for increasing the heart rate. So from the PICU, if we're going to look at the medications that we use all the time, we're going to divide them into two groups. Medications that are used as a continuous infusion and medications that are used in cardiac arrest. The cardiac arrest medications in pediatrics are very simple. I'll just say I'll just say a list of the drugs, and most of the time you can get away by just knowing epinephrine. Give epi. And some of the medications that are used as a continuous infusion are also the drugs that are used as cardiac arrest medications. So before we go into all of that, I'm going to just say a few words about the receptors and the receptor types and physiology. And I know a lot of you guys, this is something that maybe you have not used for a long, long period of time, and just getting yourself back into the language might be difficult, but we're going to try to just minimize it as much as possible. So according to the receptor type, medications are going to act. The types of receptors that we have alpha receptors, beta receptors, and dopaminergic receptors. We also have vasopressin receptors. The alpha receptors, they could be divided into alpha 1 and alpha 2. And just for you guys to keep it simple, alpha 1, vasoconstriction. Alpha 2, some vasodilatation. So if you just think about it, alpha 1 is vasoconstriction, alpha 2 is vasodilatation, and this is all that you need to know about the alpha receptors. The beta receptors, I mean, something that you use quite a lot as general pediatricians are your beta 2 agonists. And these beta 2 agonists, the biggest example is salbutamol or albuterol. And then your beta 1 receptors are actually the ones who have direct effect on the heart, and they're going to give you the inotropic effect, which is increasing the contractility, and the chronotropic effect, which is going to increase the heart rate. The beta 2 receptors also, they have some vasodilatory effect. So if we just sum it back again, alpha 1 vasoconstriction, alpha 2 vasodilatation, beta 1 heart, beta 2 bronchodilation, and some vasodilatation. And then there are the dopaminergic receptors, which are the dopa 1 and the dopa 2, and they are considered as splanchnic vasodilators. And then it starts to get a little bit complicated, but I just want to give you an idea about how great the human body is. I mean, for you to get an effect, it takes a lot of steps, and we take it for granted that our body is going to react the way it does. And this is all mediated through receptors, and the receptors are actually, the receptors that we have for catecholamines are found on the cell surface. So because the types of receptors, if anybody remembers, we have the cell surface receptors, we have the intracellular receptors, we have ligand-related receptors. So the receptors for catecholamines are actually cell surface receptors. And their effect is actually through G proteins. And the G proteins, they're complicated. They sit on the cell side, and they bind. The ligand is going to bind to the receptor. The receptor is going to activate the protein G. The G protein is going to cleave into. It has 3 subunits. One of the subunits is going to remain active. The rest of the subunits are not going to remain active, and they're going to circulate back into the cell. So it's just to give you an idea about. It's not something that is very simple. Some of the G proteins are stimulatory, some of them are inhibitory, and the way that they work is they work through cyclic AMP. So if we take a look at those receptors, this is how it looks like. And oops. No, I've gone through all of the slides. So basically, the ligand is going to bind to the receptor is going to affect the G protein, and according to the G protein that is being stimulated, you're going to get either a stimulatory effect or you're going to get an inhibitory effect. So what are the medications that we commonly use and are names that you might want to remember? Via continuous infusion, we use epi, we use norepi, we use dopa, we use Debute, we use milrinone, sodium nitroprusside, and recently there's a lot of hype about the use of vasopressin, and there's one of the newer drugs which is known as levosimendan, and this is one of the newer drugs that have come into play. The drugs that we use during arrest, if you come out of this talk just remembering epinephrine, perfect, and then lidocaine, and the rest, they fall somewhere in between the algorithms. So if you remember lidocaine and epi, you're cool. And then amiodarone, in the past they used to recommend for VFib and VTAC to use amio, and then as a second best is lidocaine, and then they rechanged things back again, so right now lidocaine and amio are equal. So if you remember epi and lidocaine, you're great. So what about epi? Epi is a drug that is, the effect of epinephrine depends on the level of epinephrine that you're using. If you're using a small dose, what you get out of it is mainly a beta-1 effect. And as you increase the dose, you're going to start getting some more alpha effect, and then what you get is mainly alpha effect. So what are the indications for using epi? It's used in cases of low cardiac output. It's used in sepsis. It's also used, you use it also in asthma. You use epi in cardiac arrest. So it's a drug that is nice for us to know about. So the dose that we want to mainly be talking about, which gives us mainly a beta-1 and beta-2 stimulation, is the smaller dose of epi. And that is the dose between 0.05 to 0.3. Anything which is higher than 0.3, you're going to start getting a mix of beta and alpha, and then anything which is higher than 2, you're going to get mostly alpha effect. The beta-1, beta-2 effect, you're going to get the inotropy, and you're going to get some mild vasodilatation. And then as you start getting the mix of the beta and the alpha, you're going to get the increase in the cardiac output or the inotropy, and you will also start getting some of the vasoconstriction. And when you use the bigger doses of epinephrine, what you're going to end up with is the vasoconstriction. And hence the dose that we use in cardiac arrest, you use it for the vasoconstriction effect so that you can improve the cardiac output, improve coronary perfusion, and give the heart a kickstart. The side effects of epinephrine, we all know that it causes chronotropy, so it can give you tachyarrhythmias. Sometimes it might increase myocardial oxygen consumption and hence leading to ischemia. And this is why our adult colleagues, they don't like epi as much as we do as pediatricians. Kids have great hearts. They haven't abused their bodies yet. So their coronaries most of the time are usually good. So this makes us get away with that. It can cause a decrease in the splanchnic and hepatic circulation, and this might lead to a rise in the AST and ALT, and this is what you actually start seeing when you use the bigger doses of epinephrine. And then also it can cause by itself lactic acidosis, and remember, lactic acidosis is one of the things that we look for the resolving of sepsis, so that might be a confounder. And then it can also cause hyperglycemia, so you're giving them fluids, and then you start them on epi, and they start peeing out whatever fluids that you're giving them. Dopa is a drug that we all are familiar with and we're comfortable with using because it's old, it's there, it's been used for so long. And also Dopa, its effect is according to its level. So when you're starting off to less than 5, what you're getting is the dopaminergic effect. When you go from 5 to 10, you're starting to get the beta effect. And as you go higher than 10, you're going to start getting more of the alpha. And then after that, you get pure alpha effect. In the past, it was the drug that was of choice for the use in sepsis or septic shock. It was your drug of choice to start off with. In kiddos that were considered as fluid resistant, you would start off with dopamine. Plus, it's the drug that is used for post-resuscitation stabilization. Dopa comes with a list of side effects. So whenever, right now, I mean, a lot of us are comfortable with starting Dopa. Think about the side effects and think about whether your comfort actually goes with the list of side effects that Dopa comes with. So it can cause arrhythmias, and this is why adults actually don't like it, because of the arrhythmia. It can increase oxidative stress. It can suppress pro-inflammatory cytokines and increase the inhibitory, the anti-inflammatory cytokine production, thus leading to immune suppression. So if you have an immune suppressed host, do you really want to be starting them on Dopa? It also suppresses growth hormone, and in young children, you don't know what their response is going to be. And you can get desensitization, receptor desensitization with the use of Dopa. So whenever you want to think about using dopamine, start thinking, is it the drug that you want to use? I'll tell you what, me at a personal level, it's so much easier for me to start off Dopa, especially peripheral Dopa, because I'm comfortable that that even if it infiltrates, it's not going to cause major damage as much if I'm going to start epinephrine as a first-line drug. But then it comes with its list of side effects. Norepi, this is the drug that adults love. They love it, they love it, they love it, they use it the whole time. And mainly, the main reason why they use it as the first line for sepsis, septic shock, fluid refractory septic shock, mainly in patients who have vasomotor instability or they have warm shock. In children, we use it for warm shock a lot of times. It has both an alpha effect and a beta effect, so it gives you inotropy and vasopressor effect as well. The infusion can range between 0.05 to 2 to 3 mics per kilo per minute. The problem with norepinephrine is also that if it infiltrates, if you're giving it through peripheral IV, you can end up with some damage. So this is why a lot of times we don't like using it initially, but if you start off with a small dose for kiddos who have warm sepsis, you can get away with using it through a PIV until you actually get a central venous line, or you could always use it through an IO, an intraosseous. The side effects of it is, like we said, it can cause compromised perfusion, and it can also affect the splanchnic circulation as well. Debut, this is the drug that is used, has been the cornerstone for treatment of cardiogenic shock. It's a nice drug, it's synthetic, it could be given through a PIV. It gives you both chronotropic and inotropy, and it also causes some vasodilatation, so cardiologists, they love it. Adult doctors, they don't love it so much because of the tachyarrhythmias that it can cause. Okay. Milrinone is another drug that is loved by our cardiologists, and it works in a totally different way than other catecholamines. And what it does, it gives two things. It gives inotropy and it also gives vasodilatation, so it's considered an afterload reducer, so that's really great for the heart, in addition to the fact that it improves the contractility of the heart. So it's a drug that is used for kids that are post-bypass, for kids with congestive heart failure, cardiogenic shock, and it's also one of the drugs that are used for septic shock. Amrinone is the original drug that came out with, but it has more thrombocytopenia than milrinone does. Milrinone is the drug that is currently in use. A few words about some of the vasodilators that are used. The drug that is used as a continuous infusion and can help out in cases of high systemic vascular resistance and kiddos who have decreased cardiac output is using Nitroprusside. Nitroprusside gives both arterial and venous dilatation. The only problem with Nitroprusside is you have to monitor levels. And at some point of time, there was an international actually deficiency in it. It was not found. Okay, Vasopressin. Vasopressin is a drug that when you think about it, you think about the pituitary, and you say, okay, so why am I going to use vasopressin? In patients who are catecholamine resistant and they are in a state of shock, vasopressin works on a different receptors. So with that way, you could actually improve your blood pressure, but it's not considered as first-line therapy, it's second-line therapy or third-line therapy. Levosimendan is a new drug, actually. I don't think it's found in Jordan, right, Khaled? You have it? Okay, yeah, I didn't know that it was found, actually. So it's a calcium sensitizer, and it binds troponin C, stabilizes calcium, and it enhances contractility. It's used in cases of a failing myocardium post-bypass. And it gives you both a lusitropic and an inotropic effect. We have not used it at KHCC. I've used it at Sidra, but not at KHCC. So what is the change in practice that they're talking about, actually? There are a couple of studies that, first of all, I'm going to talk about the surviving sepsis, not the surviving sepsis, actually, because those were not part of the surviving sepsis campaign guidelines. They came out through the American College of Critical Care Medicine, and it's about the guidelines for management of septic shock in children. And the algorithm, I think most of you guys are familiar with the algorithm. The algorithm is very simple. Push fluids, fluids until you get up to 60 cc per kilo, and then you would consider your patient as fluid resistant. If your patient is fluid resistant, you would start thinking about using catecholamines. If the patient has cold shock or even warm shock, you can start off by epinephrine, and then if your patient has warm shock and you're comfortable with using norepinephrine, you can use norepinephrine. Dopamine is no longer the drug that they're recommending as a first choice, and this has come as a change in practice. The dose of epinephrine that is recommended in the guideline is actually from 0.05 to 0.3 mics per kilo per minute. So sometimes, I mean, in some of our practices, we might use higher doses of epinephrine than this dose, but the recommended dose is 0.3 mics per kilo per minute. And then if the patient is considered as catecholamine resistant shock, you need to start thinking about does the patient need steroids or not? And then if the patient is actually catecholamine resistant and he's steroid resistant, start thinking about looking at your central venous saturations and deciding what other medications you need to give. And then it goes all the way down to putting your patient on ECMO. So what was the reason for the change in practice? I mean, dopamine has been the drug that we have been using forever. Why did we suddenly decide that we don't want to use dopa and we want to go start off with epinephrine as a first drug? Actually, the Europeans have started using epi a long time ago as their first choice. I mean, I remember in one of the conferences in 2011, everybody was talking about epi. Adult doctors, they don't use dopa at all. This is one of the things because of the side effects that they have seen with dopa. And then when they looked at evidence-based medicine, there are a couple of studies that came out in 2015 and 2016 that suggested that epinephrine is more superior than dopa. The first study was a study that was published in Critical Care Medicine, and it was basically a double-blinded prospective randomized trial. And it was in one ICU in São Paulo, Brazil. And if you think about it, I mean, doing pediatric studies is so difficult. It's not easy. Doing a randomized pediatric study in a critically ill pediatric population is not something easily carry out. And this was over an extensive period of time, over a period of 4 years. And what they did is they randomized patients into 2 groups. And the outcome measures that they looked into, they looked at patients who were considered as fluid-resistant shock and were either put into the arm of DOPA or Epi, and they looked at their mortality rate after 28 days. And then the secondary outcome was looking into hospital-associated infections and the need for other vasoactive drugs and other things such as organ dysfunction scores. The patients that they included were the age group between 1 month to 15 years, so it's a very wide and representative age group. They excluded patients who were DNR and those who refused to participate and those who were on other drugs before they transported to the hospital. And the protocol that they had, they randomized patients into either receiving DOPA or receiving epinephrine. And the DOPA dose was somewhere between 5 to 10, and the Epi was from 0.1 to 0.3. And they didn't wait until patients got central venous line, actually. They started off with PIVs until central venous lines were readily available. And the number of patients is not bad in considering to a pediatric study. There are 100-some patients on the first arm and 100 and some patients on the other arm. And their results actually were quite interesting. It was the DOPA group, they had a higher mortality rate, which is about 21%, versus 7% in the Epi group. So that's really significant. And so Epi was associated with an odds risk for survival of about 6.5%. And if you look at their Kaplan-Meier curves, they're very impressive. There was also a higher risk of health-associated infections, and early administration of patients was associated epinephrine was associated with higher or increased survival in these patients. There are some limitations to the studies, is that did they use equal doses of DOPA and Epi, and when they had to use other vasopressor because patients were not responsive, is it because the institution had a preference towards Epi? But this is a very nice study. And there's another study also that came out looking at DOPA and Epi, and this was a study that was in India. The number of patients is not really big, is about 30 on each arm. But what they had was a very interesting observation, is that even though there was no difference in survival of both groups, the Epi group, they had lower incidence of sequential organ failing, and they also had a higher incidence of resolving of their shock in the first few hours. So, with that, is that convincing enough for you to start using epinephrine first rather than DOPA? Who would start using Epi now, before DOPA? Not a lot of people. Okay. All right. So, yes. So basically, just to say that we use a lot of cardiovascular drugs, whether we choose that or we don't choose it. Sometimes you're doc up the road and you have to start off those codes, and you have to start off patients on some medications. And then just get yourself a bit familiarized with some of the receptor physiology, so that whenever they're saying alpha, beta, and they're throwing all that alphabet soup at you, you'll be able to understand what we're talking about and why are we choosing this drug versus that drug. Epinephrine could be used through a PIV until you can have a central venous line available, or you can always use it through an IO. IO with the use of intraosseous guns IO guns are amazing. And it can get you access real quick, and it can sustain you for a while until you can get further help. And then Epi is a drug of choice to be used as first line in a lot of scenarios, especially in septic shock versus dopamine. Thank you very much.